So I'm already prepared here and started recording for YouTube as well. It's a pleasure to have everybody here again. And again, as I said, so I'm already prepared here and started recording for YouTube as well. It's a pleasure to have everybody here. And the good thing is that we can interact. The good thing of these teachings and relationships is that we can relate, talk, and discuss whatever we do the same or different. And this is for me of utmost importance. And it's been a while I'm involved in vitreoretinal surgery, and a short history is that when I went to Toronto, Canada for my retinal fellowship over there, I had already done a retinal fellowship here in Goiânia, Brazil, and that was a long time ago, 1997. And before 1997, I was visiting there as an observer before I got my retinal fellowship. And interesting is that by that time, we still did the Lander system, not the wide-angle system, and the wide-angle system was taken off. This is interesting how things had an evolution over time. You know, today we have the small gauge surgery. It's much better. This for me is the best thing, and technical maneuvers and new instruments. So it's good to be in a retinal fellowship, involved on it with you and with the residents these times as compared to times before. We have so much to add and to participate and to be part of, that we feel very honored for that. And also new equipment, new instruments, new OCTs, machines. We started with, RTA, SLOs. Now we have good OCTs, better OCTs. And this is great for us. And Jadip, should I start our talk?
Yes, sir. Yes, sir. Please.
Hi, Ashwara. You are okay? Everything is all right? And there is somebody new today, Manasa Penumecha. How are you?
Yes, sir. I'm good, sir. I'm good, sir.
You are from Adytia?
Hello?
Adytia
No, sir.
Jyot.
I am from Vision Care Center for Retina, working under Dr. Nageshwar Rao.
Oh, yeah. Hi, Nagesh.
Yeah.
Good case you put us to discuss. So let's go search for the lab exams and try to find the correct diagnosis. Very interesting case. We should put more cases like that. I was in Brasilia yesterday, and I saw interesting different cases. So I was in Brasilia yesterday, as I said, and we saw very interesting cases. I should start putting those cases this week, but I'm a little concerned, and we are quite busy for next Saturday. We are going to have the Retina in which you are going to participate. And thank you for sending me your video, and we are happy for that. Also, Saturday we have all the other meetings, and online it's a meeting from Cordoba, Argentina as well, which is going to be displayed. We just sent the videos, and they're going to be displaying our videos there. And Retina will be cool, and I hope you guys are participating. And just before I start, I will just show a small presentation here for our Retina. Also, Natarajan will be there. It's always an honor for us. And Natarajan started this thing too, and he is one of the founders. And let me share the screen over here. I guess can you see my screen now? I guess so. So I will share this Retina something. Just a sec. Yeah, I think the screen is enlarged now. We are getting used to this Zoom. It's so good, you know, that we can share. And the good thing is that we have already 10 countries to participate. And I guess War and Vibe have set it from New Delhi is there too, and Dr. Natarajan, that gives us always an honor for that. And I have here my professor, Rob Deveni. He's from Canada. He's one of the founders. He might not be able to participate, but he is always there. You know, honor for us to have professors like Dr. Wai-Chim Lam from Toronto, where we did our Retina Fellowship as well, and friends like Yuzuki Oshima and Lawrence Chong is going to be the keynote speakers, and everybody else here. So they are very close friends, and we are always honored for that. So I will start my presentation. Can you see the keynote presentation? I'm going to mix the presentation with the epiretinal membrane subject. And on the way, we are going to go with a short review of the epiretinal membranes, but also we are going to show you guys whatever we do, what is our preference, whatever we go and do, maybe different on this subject. So let me grab the keynote here and play slideshow so everybody can see the screen. Yeah, it's pretty cool. Can you see Nagaswar?
Yes, I can see.
Okay, so let us talk about epiretinal membranes, and a quick review for epiretinal membranes is that let me just roll over this. Just a second, make it a little smaller. And okay, yeah. A quick resume of the concept of epiretinal membranes: cellular proliferation in the inner retinal surface, and we have other names for it, such as premacular fibroplasia, macular pucker, cellophane retinopathy, premacular gliosis. This is just the way people know the epiretinal membranes concept. And we started years ago with studies like the Beaver Dam Eye study and the Blue Mountains Eye study. But of course, today you see lots of more studies on that. And they were looking at the overall prevalence of epiretinal membranes in these populations, accounting for 7 to 11.8%. And the year incidence yearly of 5.3%. And bilaterality of epiretinal membranes were 19 to 31%, and with a 13.5% 5-year incidence of a second eye involved. So it's pretty common, and we should always look at the other patient's eye as well. So age distribution, we have variations among different populations, and the peak is between ages of 70 to 79, could be less, could be more, depending on those populations. And in the Beaver Dam study, epiretinal membranes were more commonly diagnosed in women at that study, but not in the Blue Mountain studies. And this could be merely due to greater survival rate of women in this age group. So that's just to show that could be different in one or other population, as we mentioned. The prevalence of epiretinal membrane appears to vary with ethnicity, and interesting that we have a higher prevalence in Chinese participants as compared to Caucasians, and lower rates observed in Japanese. In the Blue Mountain study, the prevalence of epiretinal membrane was increased following cataract surgery, 16.8%, and retinal vein occlusions. And when we talk about epiretinal membranes, you're going to see we have the differentiation between the primary and the secondary epiretinal membranes. All these things account for different statistics. And we know that, as I said, there is idiopathic. You don't find good reason for the epiretinal membrane to be there, or associated ocular diseases, and secondary when a pre-existing or a coexisting condition has a significant impact on development. And iatrogenic, you see with surgeries, with excessive lasers, for example, with not dealing so well with PVRs. And so you could do a very extensive retinotomy, for example, in a place where it shouldn't be. And so all these things could, even the laser in the office in an excessive way, could account for an epiretinal membranes. And as I said, idiopathic, and lots of causes for the secondary causes of epiretinal membranes, as you see here, retinal vascular diseases, vascular occlusions, diabetic retinopathy, very common, telangiectasis, microaneurism, aneurysm, sickle cell retinopathy, intraocular inflammation, trauma, retinal detachment, and retinal tears, intraocular tumors, retinal angiomas, hamartomas, retinal dystrophies, and retinitis pigmentosa, among others, many others. And I have here, just to take off, some videos of mine that we published out of YouTube, and I separated 6 videos, but I'm not going to play the videos totally, but just some parts to show what is interesting that we have here. Taut epiretinal membrane ILM peel technique. So that comes to the concern whether we should do the 2 surgeries at a time, or we should just do one, and for whatever reason, and why we would be doing that.
Membrane ILM peel. That's a case designed for taut epiretinal membranes. You can notice that FA and OCTs that the epiretinal membrane is very adherent and quickly root on autofluorescence. The brain is very adherent.
As you see here, the OCT, it's a taut epiretinal membrane. Interesting to see is when we have an epiretinal membrane that might be very adherent or not. In such a case like this, you have the membrane very attached, very adherent, that could make things a little more more difficult. But it's good that we have the OCT so that we take a very good look at the retinal structure. As you see here, the OCT, and you see the area of the retinal membrane and distortions, and especially in those areas we have to be very careful with the distortions at the IZ, EZ zones.
that the epiretinal membrane is very adherent.
And the good thing is that I'm showing here autofluorescence. Autofluorescence shows, especially whether the membrane is deeply rooted into the retina. That is a very important information. If you could always use autofluorescence.
Root on autofluorescence.
And as you see here, the OCT.
Top to bottom discloses the irregularity of the epiretinal membrane.
So how the retinal membrane leaves the retina so irregular.
Chart now the inverted 23-gauge
And we are carrying on with
contact lens.
inverted contact lens.
Brilliant blue.
And we are using brilliant blue. Interesting to compare.
As for comparative reasons, to help us decide on the right point to the appropriate PL.
So the thing is, where should we grab the retinal membrane when it's so taut and so adherent? So you should find the correct place. The good thing is that we rely also on dyes, so we could stain well the ILM. And when we see the ILM, it's possible to see the epiretinal membrane by contrast. Times ago, people said, no, the ILM, you can only see the ILM, you cannot see the epiretinal membrane, but by contrast, you see them both. It's very interesting.
Helps to see the macular adhesions in the states where the membrane is more adherent. To start the PL, they counterclockwise.
So in this way, we are removing the internal limiting membrane, but beforehand, we removed the epiretinal membrane. And so we removed both at a time. And so here, you see here the comparison with the autofluorescence, so as to help you decide where to go. It's always good to have them both.
To start the PL, they counterclockwise direction. We grab the edges of the membrane. Since the PL is a hard one, we move it to a clockwise direction.
As you see here,
Back whenever we allow. We keep going, relieving the attractions and completing the PL 360 degrees.
and so why is it important to remove the ILM together with the epiretinal membrane in some, not all, very taut and tough cases? Because you see by the OCT, you see the epiretinal membrane, but it's so adherent, and sometimes you have defects on the ILM, and from these defects, you have the Miller cells and growing through these defects and creating scaffold on the retinal surface, thus increasing the likelihood of worsening the epiretinal membrane. So that's one of the reasons why some people also do retinal detachment surgery, and to avoid these PVRs, they also remove the internal limiting membrane. So it's what we call the double peel. We in this case with endolaser and air fluid exchange as well. You see here, as you see on the OCT picture on the middle, you see the epiretinal membrane. You see, but it's so adherent, and when you have a secondary epiretinal membrane, sometimes you have focal adhesions at the retinal surface, on the retinal surface. But in this case, it because it's primary, so it keeps parallel, and you don't see this PVD, you don't see vitreomacular traction. So you gotta grab it, and sometimes it's difficult to remove it without having to remove the ILM. In this case, we decided to remove the ILM, and so we removed the upper retinal membrane as well. As you see, this is a very beautiful picture. That's what we call the double pill. So this was the first example, and we go on with the classification and from the basics, as I said, to the advanced. So as a guest described the disease, grade 0 cellophane maculopathy. These are usually asymptomatic membranes and could be incidental finding in the retinal examination. So you see different colors. You should look both eyes, and you see this shiny reflex. We usually call it cellophane maculopathy. And when you have some wrinkling at the macular surface, and then comes to stage 1, the image, the patient starts to complain of distorted, of blurred vision as well. And other symptoms that could happen rarely could be central photopsia, macropsia, monocular diplopia, and you should look at 2 eyes. And monocular diplopia, that means that if you cover one eye and the one eye has the other eye has a retinal membrane, you could see double out of this eye. So binocular diplopia would be you are seeing double, but with both eyes wide open. In this case, if you have a retinal membrane and you want to test the eye with a retinal membrane, you cover the fellow eye, and this eye with a retinal membrane, you could see double. It's interesting to see that. And another example of grade 1, that's vision, as you see here on the his right eye, involving the vessel as well. So you gotta be very careful whether the membrane could involve not only the macular area, but distort the vessels and other structures. As you see here, stage 2. This is pretty involving in the macular surface. So approximately 80% of these patients with grade 2 retinal membranes have symptoms of blurred vision and metamorphopsia. It's more difficult to deal with. In these cases, you should go ahead and test whether the patient needs surgery. Of course, it's a little late because you could have developed more symptoms, and you could have developed vascular structural lesions because you have the membrane causing this attraction over the macular area. And now I move it on to another video here. It's in the number 2. I'll go fast with the videos and just showing whatever is more interesting, more important. This is another inverted surgery. This is Goiânia, our city, and what to do with surgery early or surgery later. And I'll go back to the title here. Early ILM peel for full thickness macular hole. Just to show that you have here this this patient was cool, you know. He just had this vitreostraction, and the vision was 20/30, and the patient had his vision worse. But the thing is that he had the PVD. The PVD, whenever we see patients with macular holes, and we not only look at epiretinal membranes, but we look at the posterior vitreous. This video is to show whether the vitreous is important, because oftentimes you don't have a PVD, you don't have a posterior vitreous detachment, but you could have this vitreomacular traction, but not in this case. The vitreous was just pulling away. And when you have the vitreous, the loose vitreous, and it escapes from the retinal surface, it could cause a macular hole. In those cases, we always look at the other eye. If the other eye has a posterior vitreous detachment, the likelihood of having macular hole is much less. This is not the subject for today, but I just want to show whether we should compare, these patients before, and so just observing when the vitreous attachments were there and after the vitreous attachments were out of the retinal surface, and then you had this in a few time you had this macular hole and cysts and structural changes. All these things you might be able to see in the epiretinal membranes as well. And important, as I showed the last case of peeling the ILM, in this case we did not have much epiretinal membrane, but just to show how it's important to peel the ILM with a good dye, with a good brilliant blue technique. So we go back to the slides, and we have here, as I said, a PVD. A PVD is present in approximately 60 to 90% of patients at the time of diagnosis. And if patient has a partial PVD and a persistent vitreomacular adhesion, they are more likely to develop CME and lower visual acuity. So in cases where PVD does not exist, and you could see some distortions from the vitreomacular traction over the retinal surface. And this shows at the image on the top, you see these microaneurysms, the image, and some hemorrhage as well, the arrow in the bottom showing. And you see at the bottom image a spontaneous avulsion of the vitreous. And this could sometimes also remove the epiretinal membrane and cause a cure for the epiretinal membrane, and the patient could not need a surgery. This is interesting. It is not so uncommon to see spontaneous avulsion of the epiretinal membrane, as you see in the picture. So you always have to observe and ask for the patient's symptoms. The patient could be scheduled for surgery today, but yesterday he had these symptoms, and I had canceled some cases where the patient, no, my vision is so much good. So it happens with a vitreous hemorrhage, for example. You're waiting for a vitrectomy, the patient has a diabetic retinopathy with vitreous hemorrhage, and the other day you are going to be operating some maybe 1 month, 3 weeks, or a month later. The patient said, no, my vision is so much good. So you are taking a look, you don't see vitreous hemorrhage as well. So that could happen because the epiretinal membrane was attached, and now it's not attached anymore, and so that happens, and could be a spontaneous avulsion. And as you see here, the structural changes that you see when you have these epiretinal membranes so attached. You see on the left image, you see the color peak showing the macular involvement. In the middle picture, you see the lining of the epiretinal membrane full thickness, and you see cysts on the right image, intraretinal cysts, and the changes as well. You could have macular pseudo holes, lamellar holes, and also that could involve with a macular hole as well. So usually you see in this image you see pseudo holes, and that could, in general, these epiretinal membranes don't get worse over time, but if you have a cutoff for operating patients with 20, 60 or less you could be having a better prognosis as of to wait until the vision gets blurred, and you could possibly be happy with a vision of 2000, but it is not good anyways. So I tend to operate, in my experience, in patients with 2050 or less, even 2040, when you see the OCT and you have a traction, and I tend to operate a lot earlier. And uh, you have here in the image, in red, you have an epiretinal membrane with PVR. You see lots of more RPE pigmented cells as opposed to the bluish image on the right side, where you see primary epiretinal membrane, and you see it more uh, as a line. So there are some causes for that, and you should be looking at the extension of these causes and involvement in the macular area. So you gotta be a lot more careful when operating on the eye with PVR and the retinal membrane, because that might be connecting cells, RPE, vessels. So it's a lot worse, and they are more heavily pigmented melanin, and you have the possibility of retinal ischemia and neovascular proliferations, and have a major vascular components as well. And that could be an evidence that epiretinal membrane formation represents a reactive gliosis in response to retinal injury or disease involving inflammatory and glial cells as well. And we have here the growth factors that could be involved. This is a picture from the Ryan book, updated Ryan book. So you have growth factors that could be involved in the formation of epiretinal membranes. There are lots of them. We not always look for them, but it's good to know that they exist, they are there. We should always take them into considerations. And you know that the milieu cells occupies and go all over the retina, as I said in slides before, that the milieu cell could find defects in the internal limiting membranes, superficial surface defects, and that could grow towards the ILM and create that scaffold and contribute for the formation of the epiretinal membrane. That's what, as I said in slides before, that we should think in some cases of doing the retinal membrane surgery also after retinal detachment surgery, and even considering pitting the ILM for retinal detachments and PVR cases. So you see that the response of milieu cells and other cells that go through all over the retina, they could create the scaffold and cause the worsening of the case and the redetachments and things. So as you see here, activation of milieu cells may continue even once the original stimulus has been withdrawn. As I said, in the retinal detachment surgery, even though you did a very good retinal detachment surgery, you could still have the milieu cells activation because they migrate through the ILM, and then the case could worsen. And so you have all these structures, not only the milieu cells, but you have nervous interneurons layers, synaptic layer, photoreceptor layer. We have always to take a very good look at the outer retina, because if you have a very important traction in the retinal surface, that might influence the outer retinal areas, and with contractile actin and myofibroblasts as well, and the membranes, and these could distort the retinal vasculature with or without breaks, and that could break the blood-retinal barrier as well. So we always be very careful. And you see on the OCT on the left, you see this is still in epiretinal membrane, not very easy to catch. You might well lose it, but you see that the foveal contour, the foveal shape is not there anymore. And you see the lining on red. You see that the epiretinal membrane is there. This is that could be classified as a taut one, but then you should go after the membrane during surgery and remove it. You see a better epiretinal membrane better, but it's not good. But on the right, you see the easier to catch the epiretinal membrane. On the right side, still with distortion of the foveal area and shape. And you have the OCT down to show the normal RPE shape. And if you have the SDOCT, as we discussed in previous lectures, it's better that you have the spectral domain OCT as opposed to the time domain and other machines. That you should look at the IS-OS junction disruption and thickening of the central macula and other areas. And it's interesting that Oster et al. Found that the IS-OS junction was a more useful predictor of visual acuity when compared with central macular thickness. When you have the epiretinal membrane just pulling on the retinal surface, and you have the macular thickness increase, the central macular thickness, as we see CMT, and it's not as important as you have the distortion of the IS-OS junction, the area of the photoreceptors there. So you have to, you need to have a very good OCT to take a look on these changes, because the visual acuity could be getting worse, but would not take too long to get worse if you have this involvement of IS-OS junctions, as the central macular thickness could wait a little more until you treat the epiretinal membrane. And now I have here another case. Let me go here, the triple peel. I think I showed this case in other opportunities. So the decision is that you have three things going on at the same time. You have here an epiretinal membrane, you have the PVD, and you also have the internal limiting membrane. All taking account for this image here. You see, you have a vitreomacular traction, very important, of the retinal area. You can see on the left bottom image, you see the lining of the epiretinal membrane, and you see distortions in the IZ zones and foveal area. You don't see the foveal shape anymore, as you follow with the OCT above. So difficult case to deal with. And retinal thickening as well. You see, if you go only here, you see, okay, it's just if you have only this image, this is just epiretinal membrane, so we go for the surgery. But if you keep going with the OCT, you're going to see how severe it is. And so the thing, from my experience, this patient is phakic, is that you should always operate on this patient. After I did the core vitrectomy, I'm here with the macular lens, because the macular lens makes you see the reflex, and you see all membranes. I'm grabbing here now with the macular lens, I'm grabbing the adherent, very adherent hyaloid there. I still go around the macula, And I gotta be very careful at this time because I remember from the OCT, if I pull it too forcefully, I'm gonna open up a hole over there. And so I have to be extra careful here. Now I go horizontal. I don't pull vertically. This is what I call the first peel. So you're peeling the hyaloid, but you're very slow and going horizontally. This is a normal pace. Very slow to detach it. And when you detach it, you search for the hyaloid, you lift it up, and they remove it from the macular area. So that was the first membrane to be removed. And now I will go towards the second peel. The second peel is the upper retinal membrane that was lifted up when we removed the hyaloid. And now I'm removing down below the upper retinal membrane. You see that the cutter is flush on the retinal surface, not touching it. You got to be very careful. You got to be superficial with a high-speed cut and not very much aspiration, and don't go vertical up. Otherwise, you may tear and cause a hole in the retinal surface. And after I removed these two membranes that I called membrane, the first, the PVD, is the hyaloid is not a membrane with vitreous and hyaloid. So, but I called in this case the first view, and then I removed the upper retinal membrane. And because you have so much distortion in the macular surface there, you see the macular, the fovea is still distorted. So I decided to do the third peel, which is the ILM peel, to get the foveal area more stable. So before doing that, I'm carrying on with an fluid exchange. And after fluid exchange, I will forward a little bit. So I will go on with brilliant blue. I love to use brilliant blue. Of course, when I stain with the brilliant blue, immediately after staining, I turn on the fusion line again, and I don't leave the brilliant blue for long, maybe 1 minute there, and then I go on with vitrectomy to remove the excessive brilliant blue. Now I'm getting the internal limiting membrane. But you see that the distortions are getting more stable now. And you should have a very good macular lens. If you have a very good macular lens, and then everything is so good to do, you stop and go. It's like watching a movie. You go, as I mentioned here, it looks like a capsulorhexis. You go, if you bring here and there, you don't need, in these cases, very adherent ILMs, and in such cases like that, you don't need to be fast. Go slow, take your pace, and you're going to be removing all tractions, and it's pretty sure that the case is going to be okay. And so I will forward a little bit. I'm still removing the ILM over here, and I'll be doing this fluid exchange, and as you see, the distortion is disappeared. It's a lot better. You see, you remember the autofluorescence from the beginning of this case. It's completely different. You don't see the distortion anymore. The rooted membranes, all membranes were deeply rooted in the macular area. So this is a lot better now, a lot better. And the patient's visual acuity got better. You don't see the edema anymore, the tractants. And if you compare the two OCTs up and down before and after surgery, you see the resolution, still some edema, of course, because this was taken 1 month out, 1 month later after surgery. But you see that the case is getting better. And if necessary, this case is going to be referred for injecting as well. So we are coming to the end here. And so always look at the easy areas, and to look at integrity of these areas, and I have a good OCT to look at for distortions, the presence of the easy zone or absence, and this is important to uh, to try to catch all changes before and the surgery, and also giving you an update on the possibility of better visual acuity and when you start the surgery and not to take too long. And as you see here, the central foveal thickness, and you see here the cone outer segment. This is important to see these areas, and you see the central foveal thickness as well, but the area of the cost, the area of the cone outer segment areas, you have to take a very good look at it, because this distortion might cost you a good or a bad case in case you have too much distortions of this cost area, the cones, and as compared to the central foveal thickness that could stand a little longer with the central foveal thickness a little wider, but the cost area from the cones, outer segments, that could cost you a good or a better outcome. And the IS-OS junction appears to be disrupted during the early stages of epiretinal membrane. So you should catch these epiretinal membranes very early. You don't go only for the visual acuity. The visual acuity is okay, so I want to operate, I will just wait a little longer. But if it goes from the classifications from 0 towards 3, and then you have a significantly higher incidence of IS-OS disruptions there. So you gotta take a very good look at those structures there, thinking that you have the whole structure, the overall structure that takes account of the membranes. Also, don't forget the FA. FA is important, as you see here, vascular distortions, and you see edema, you see tractions, and you see straightening of the retinal vessels. And the autofluorescence, as I said, is good, that sometimes you have ghost vessels, and meaning that the vessels move with the traction, and you have printings, you have changes, and you have, you remember the last case I just showed you, you have these epiretinal membranes before deeply rooted with the OCT autofluorescence and the autofluorescence, and then I showed you after the case the post-operative autofluorescence. It was completely different. And so talking about surgical techniques, these are the techniques I use. Vital dyes, I like using the brilliant blue. I'm used to that. I think you gotta be using whatever it's good for you, but some countries don't allow you to have the brilliant blue. For example, Dr. Wai-Chin Lam, Professor Wai-Chin Lam was saying that in Hong Kong, and they cannot use brilliant blue, but they have to rely on very diluted triple blue, the same for the cataract, but doesn't stain as well, but it still is possible to do the surgery. If you have a good macular lens, you gotta have a very good macular lens. Engaging techniques, as I showed you the cases, you if you have an OCT before the surgery, you take it to the OR, and you know where the membrane is more adherent or where the membrane is less adherent. You go after the membrane exactly where you want to be, and where you know where it's more detached or not. If you have the possibility of doing OCT during the surgery, it's good too. Some microscopes have this. Of course, it makes the surgery the OR more expensive, but it's a good thing. And PVD induction. As I said, you don't need only to induce PVD and pulling everything away from the retinal surface. Otherwise, you could cause problems and macular holes and other things that I mentioned. So be very careful when inducting the PVD. go slow, go your pace, and if you want to use dyes to better see the vitreous, for example, triamcinolone is good. Some people use. I don't use that because with my macular lenses and other wide-angle lenses, I see well the vitreous. But it's good if you have and you wanna use, but be very careful, especially for those residents and fellows that are starting. If you use the triamcinolone, you might engage something that is not vitreous, or you pull on the vitreous too forcefully and create a hole and things, and be very careful and go start core vitrectomy slow and then keep approaching towards the retinal surface. And I think I showed most of the cases here, and most of what I do different is these are all from my iTube. I like doing double peel whenever it's necessary. For tau retinal membranes, this is a very interesting case. I think it's my last case from the showing today. This is our inverted vitrectomy. That's why I put this helicopter. So this is very taut ILM epiretinal membrane, taut epiretinal, and I do here the. This is the one I showed. Yeah, just to show you again. As you see here, the OCT, the fundus autofluorescence before, and as I showed at the end of the case, the fundus autofluorescence, it's completely different if you compare them both. So be careful not to do the wrong approach. And so surgical decisions, they have to rely on, especially I go down here, cost integrity, fundus autofluorescence, that could impact the outcomes, and the integrity of the IS-OS junction is very important, that you take a very good look at the OCTs before the surgeries as well. And that's about it. I think I rushed a little bit so that we could have time for discussion. I will stop sharing now. And that was quite a long time, probably 45 minutes speaking on the subject. It's so good, this subject, that I could have spread it here. If we included macular holes, then could be another extra hour, which is going to be for 2 weeks from now, macular holes and techniques. But for epiretinal membranes, I think that we should always take a very good look at the membrane before, later, knowing the patient's history and taking the good approach. And I will tell you, when I did my residency, my cutoff was 2000, but today my cutoff is 2040. Even though the vision is good, but you see traction, you see the membrane, you see these changes, you should tell the patients, the family, that the patient might need the surgery before. And what the point of postponing the surgery if the patient is getting worse? So you have to pay attention to those things. Thank you very much. Jaydeep, do you have any comments? Professor Jaydeep?
Thank you, sir. It was an excellent presentation and wonderful videos with great description of the techniques. I think I don't have anything much to add. I think what you said makes perfect sense. The only thing which I would say is about diagnosis. Maybe sometimes there could be some membranes which are due to inflammatory causes, or sometimes you can misdiagnose it, something like a combined hematoma of the retina and RP. which also looks like an epiretinal membrane, and you might, in the, especially in your early years, you might say, oh, this looks like a very bad membrane, let's take it out. But the combined hematomas don't have very good prognosis if you operate them. So some things like that you need to keep a close watch on, what are you dealing with. And as you said, the OCT plays a very crucial role. So we have to look at the OCT very carefully, and the history. And also, one thing which I would like to ask you is how do you follow up these patients? I mean, my threshold was to around say 618, or you can say a little worse than 2040. But yeah, as you said, there are certain characteristics which we need to look into when it comes to the OCT. And also, it's a little difficult to convince a patient with a relatively good vision to get operated. So how do you follow up these cases? And when
I
would you decide?
follow. Yeah, I follow these cases. I like taking notes on all patients. I take notes on the patients from the charts. And so I have in my iPhone that is connected with the computer here, with the Mac, I put the patient's number. And when the patient doesn't have a number, which is not usually the case, I have the date of birth, and I keep following. Now you have now 2040, but this membrane is very tiny, so we should wait a little bit more. So you should come in 3 months, and I know he's going to come in 3 months. When I want to know, because we see so many patients at the iBank Foundation, it's like having so many that I cannot remember all patients. And I remember I had this patient that had this good visual, good prognosis, good outcome, and good visual acuity. And so at the top of my notes, I write epiretinal membranes, good outcome patients, and this patient should be seen soon. So I never lose the track of the patients, and I also always tell them that they have to come back. And I have to tell you, 80% or more, they all come back. The patient that I showed the case, we were observing this patient. He was cool, but after 6 months, he developed this macular hole. He had only the detachment, no epiretinal membranes, but then he came and we operated him right away. So he didn't wait much time. So I have this system. We have all patients in the chart, in the computer, in the system of the program, but I have them myself. So whenever I do surgery, I wait for a bit for the intraocular gas, for example, to come out of the eye, and then I get the patient and I do another OCT, I do other surgeries if necessary, but usually I follow them with the OCT. If they are okay, we just keep following. And it's a good way to not to lose track of the patients. And I always talk to them because most of my patients I see in the teaching basis unit, that's the iBank Foundation. So we are together with residents and fellows. We talk a lot to the patients. We talk and explain this and that. I had this patient that I saw a week ago that had retinal detachment, a traumatic retinal detachment surgery 2 years ago. He was scheduled to remove the silicone oil. He had the silicone oil removed, and then he developed this retinal membrane. He was scheduled to do the retinal membrane peeling by the end of the last year, but then COVID times came and we could not do that. And he came complaining, "I'm very sorry, I could not come because of COVID times. I had to travel to see my family. I had to stay there. I could not leave." And so the patients, if you talk to them, they acquire this consciousness of the disease, and they see we are interested as well, and that we really are. And so I think, JD, the best guess, the best thing is to talk to our patient, and we don't miss those cases.
Right.
Aishwara, did you like the presentation? Nicole is our retinal fellow. Let me ask Nicole or Carlos. Carlos Câmara, are you still there or are you taking breakfast now? uh,
Hello.
there is
Uh,
Carlos, good to see you. So you are going to the OR now?
Could you repeat?
You are going to the OR now, operating?
Yeah. I'm waiting anesthetic.
Okay, okay. Rodrigo, did you have anything to add?
Hi, doctor. Was a very good presentation. Nothing.
Yeah, the good thing is, as I said, Deep, I love these presentations because we talk, we discuss, and I don't know whether Nagaswar, he's probably started surgery. I know Nagaswar starts.
yeah, he left, I think. He had
Oh, yeah,
messaged
yeah.
in between that he has to leave. So one more thing which I wanted to ask is uh, what instruments are you using? Like, do you use uh, a pick or a kind of a spatula to lift the membrane first and then use hand gripping forceps, or you directly lift with the forceps?
I usually
Or do you use
do.
MVR sometimes to
No, I don't use
give a nick?
MVR. No, I don't use
Doctor,
MVR blades anymore. I rarely use them 23 gauge with like a pick, so
Yeah,
as
yeah.
to lift the membranes. But I'm very comfortable those days with good instruments. We have good rotation, good cuts 5,000 and even more. I'm very comfortable using the cutter itself after doing the core vitrectomy and using the cutter to lift the membranes and especially the hyaloid because after you did the core vitrectomy and you don't have more attachments of the core vitreous on the retinal surface, so you look for the hyaloid. It is good where when the hyaloid is already detached, it's easier. But if it's not, I almost get the hyaloid from the nasal area from aspiration, not going straight towards the macula, and then I lift it up and I keep following the hyaloid just parallel to the retina surface. I go that way, horizontal. That's why we need a macula lens to do that. I love doing that with the macula lens. I don't. I use the wide angle lens just for the core vitrectomy, and then after I did everything peripheral vitrectomy, and then I go to do this work. I like using the macula lens because I see everything. I detach the
Yes.
vitreous, the nasal area, I lift it up, I keep following the vitreous and the adhesions and the hyaloid and keeping the safe distance from the macular surface. So I love using those instruments I use rarely. Today I like the 23 gauge of the cutter to do this stuff, and it works well. As you saw in this triple peel surgery, this is a very good example when we have all membranes there, and then we have. I'm considering the hyaloid as a membrane, but that's why I put it the name as triple peel. But it's good to do. No? I have a video. It's interesting. I have a video for Terson syndrome in the eye tube, Terson syndrome, where I could, with the cutter, you won't believe it. If you don't see it, you won't believe it. But I could lift the internal limiting membrane up. I started with the cutter, and then I used the backflush cannula. With the backflush cannula, I could lift the internal limiting membrane. Of course, with the pathology, with the Terson syndrome, it was loose, the internal limiting membrane.
Yeah,
But
there must be
was possible.
sub-ILM hemorrhage. So the ILM must be lifted up.
Yeah. I think we discussed the case similar to
Right.
that some months
I've
ago.
had
But
similar cases. Yeah.
yeah. That's why I mentioned it to you, because I heard that from you. And then I could lift the internal limiting membrane with the backflush cannula. Take a look, iTube there. It's an Terson syndrome, Hudson Nakamura.
Right.
It's interesting. You know, I had never done that before. So it's still
Right.
possible that it was the cutters, and if the cutter gets safer and safer with manufacturing, and if you have the opening more close to the tip, it's better than if you have it more retracted. But sometimes if you have the opening of the cutter more retracted, not so much at the end, and then you could have a safer distance, and also the ILM and the epiretinal membrane forceps. I'm using them a lot, and I like those from Catalyst, from Rumex. I use them all from Alcon. I use them all, but uh, we we are, learning different instruments, and then working on trying to actually create other other instruments for better pickup of the membranes. And uh, I don't use the, but I think it could be good thing to add the loop. Some people they use the flex loop to lift up the membranes, but I prefer the pickup technique. And it's a matter.
You peel the ILM for all cases, sir?
No, not for all the cases, but we learned it from many cases that oftentimes the Miller cells, they go straight towards the defects from the ILM, the Miller cells, and they create a scaffold for epiretinal membrane. So in some cases, like PVR, some recurrent retinal detachments, and I like doing the surgery. After I attach the retina, I put PFC, and under PFC, after doing a fluid exchange with brilliant blue, under PFC, and then I peel the ILM, because the PFC keeps the retina down, so it doesn't
Yeah.
lift. Some
In
I
RD
do that
case,
for.
that's what I do. That's what I do when there's a detachment. If I have to peel the ILM, I do it under PFC.
Yeah, I don't think we need to do the ILMPO for all cases, but in some cases where the epiretinal membrane, which is our subject here, is very attached and adherent, and you cause the overall distortion. And then if you have the ILM peeled, that happens. I mean, that helps a lot to decrease the attractants, and the outcome gets better, and you have less chances of getting post-operative PVRs.
When do you stage in such cases? Like, when do you put the brilliant blue? After removing the ERM, or you do it in the beginning?
No, at the beginning, because after vitrectomy, core vitrectomy, and peripheral vitrectomy, I do that air fluid exchange. I always do it complete air fluid exchange. And when I put brilliant blue, I stain ILM, I stain epiretinal membrane as well. Not so much intense as the ILM, but I always stain both. If you remove the hyaloid, you stain them both. So the case becomes a lot better if you see, you are seeing everything. And my last cases that I did, that I published on YouTube, I always use the brilliant blue, and by doing double peel, with the double peel, you see the two membranes. You see the epiretinal and the internal limiting, both stained.
Do you think? Yeah. Do you think when you peel out the epiretinal membrane after staining, does the ILM sometimes come out on its own under the ERM?
No. I don't think so because if I'm grabbing the apparatus membrane, it comes solidly alone, and then I have to, unless it was already, sort of detached, like in this case that I mentioned that we removed the cortical vitreous and hyaloid for Terson syndrome. So the ILM was kind of loose like that, but not usually. Not usually. I prefer to do them separate. I don't usually remove the apparatus membrane, and it comes with the internal limiting membrane. And then, because I like to do them separate, so I do the thing in the good fashion, the movement around the circular and make sure that I remove the ILM from all the macular area.
Doutor,
Sim. Yes.
queria saber a experiência dos indianos sobre o ponto de operar a membrana retiniana em termos de visão, se eles operam com a visão 20/40 ou se eles esperam um pouco mais.
Okay. JDip, Carlos is asking your cutoff for doing the surgery. 20/40, 20/50, more or less. What is your cutoff? You wait a little longer, you go for the visual acuity.
Yeah, so I was like, what I do is I'm following up the patients every 3 months, or if it's a stable membrane, every 6 months. And I was looking at the visual acuity. If it is less than 20 by, you can say 60, like 618 vision on the Snellens, that is the threshold where I decide to operate. But it also depends on the OCT. So on the OCT, as you said, I look at some of the factors like the ellipsoid zone and the traction, the iris junction, those areas,
Oh,
and
Carlos.
visual acuity. Visual acuity is one of the factors which I was giving it importance, because if the patient is asymptomatic, is not symptomatic or not complaining, then I would wait for a patient to become 618. But if the patient becomes symptomatic, I would rather, even at 20s, 40, I would still decide to operate if the patient is symptomatic.
Carlos, esse 20/40, né? E tá, assim, já começa a ter sintomas mesmo. O 20/40 é o cutoff dele. O 20/40, 20/40, he operates. Thank you for the question.
Thank you.
Excellent, thank you.
Thank you. So, Nicole, do you want to ask any question, please, if you will? Nicole is our retinal fellow as well, and Nicole and Jessica. Jessica is not here today; she's on vacation. And Nicole and Jessica and the other Carlos, they are so good. They get too much to do in practice. It's very good we have this service and getting back to normal, JD, because those COVID times, the cases, people waited a little longer, but now things are getting back to normal. And we have here also Otávio Santos. Otávio, do you want to ask any question? Quer fazer alguma pergunta? And I think that's about it. JDip, do you want to give any comment, or Aishwara, so that we close?
Sorry, I was not able to answer your question earlier. Actually, I participated for most of your presentation, but there was an emergency case in the OPD, so I got caught up with that. But whatever I heard, it was really good. So the videos also were really good. Thank you for that
Okay, all
class.
right.
I wish I was
We
not
are
today.
recording by Zoom as well. So
I'll be watching that in detail again so that I can get, because now I was very distracted when I was watching. So.
Okay, Ashwara. Do you have any? We have to decide on next week's cases, and
Yeah,
maybe.
sure. We'll talk later today, and we'll fix up the next week's class also.
Okay. So thank you very much, everybody, for participating. It was a great discussion. And it's
Yeah.
always good to be
Thank
with
you.
you. And I like when we discuss and we talk and we keep moving on like that because it's good
Dr.
to.
Hudson, I just had one question, last question. Like, suppose like it's an individual surgeon's, what confidence the surgeon has. Suppose you might feel that you can operate on a eye which is even to a 20, 40, 20, or 20, 30. How do you, what would you tell for somebody who's beginning? Somebody who's a beginner, like suppose Aishwarya finishes a fellowship and then she starts operating apparently membranes. How would you, in her practice, what would you, tell her?
Yeah, as I saw, as I said in my comments, if you are starting vitrectomy, go slow. If you have a lens, avoid the lens. If patient is pseudophakic, avoid touching too much on the IOL. Be extra careful. If you have an IOL and you have the patient was operated quite a while ago and you have posterior capsule opacity, you remove the posterior capsule so you're going to see well, very much better your epiretinal membrane when you are starting. And so the good thing is that you have the media clear. So if you have a lens which is not cataract, so try to spare the lens. If you have the intraocular lens hazy because of opacities of the posterior capsule, go towards the posterior capsule and clean it up in the center. You have a very good view, and you start with the wide angle lens. Take care of the vitreous first. Vitreous, core vitreous. Start on the core vitreous, and then don't make movements very fast. You go to the periphery, one side. If the patient has the lens, you switch hands and go the other side. Go everything very slowly and try to avoid iatrogenic breaks, but not going too peripheral. You just do vitrectomy wherever you see the vitreous. So it's important to see the vitreous, even if you have to zoom it in, zoom it out, the microscope a little more, a little less. And so if you see the vitreous, and then it's going to be cool, you're going to have a great surgery. And then before starting the macular work, the epiretinal membrane, even if it's a good outcome, membrane never starts at the foveal area. It start elsewhere. Do an fluid exchange. Use the brilliant blue, for example. And if you see it, start grabbing the membrane from the macular area, but far away from the fovea. And then if you lift an edge, take your time, take the macular lens again, use a very good tip, a very good, for example, hand grip forceps. You go after the membrane and lift it up. Go horizontal, like following the round track, and never pull it forcefully. Do everything very slow, and then you can get away with any case very good. If you start slow, with time, you're getting experience, and things are going to get faster and better. But there is no need to show or to rush on those cases.
Thank
That's
you.
my
Thank you.
advice.
Is there any role for, do you use like post surgery, as you said in one of the cases, there is some edema, residual edema that remains. So do you wait for it to go, or have you injected something like dexamethasone implant or something, given an intravitreal steroid post surgery
Yes,
for the edema?
not immediately after the surgery, but it could be an
Okay.
approach. If the patient had surgery, you could, right after surgery, inject. That's not a problem. But I like in some cases, for example, if the macula is raised, like the case I showed you, I like putting some gas, even though the gas is not very expensive, just some concentration to keep it up, keep it in their vitreous cavity, so as to uh, push on the macula, so to get everything straightened. So I wouldn't mix gas with injection at this time, but in that special case, after the patient had everything removed, but still remained some edema, then I would inject. I would do anti-angiogenics, and if it's necessary, if the edema gets chronic, and then I would choose Ozurdex, for example. And so it depends on the cases, but most cases with the vitrectomy, removal of the tractum, they go well with this edema, and edema gets better over time. How often you
Right.
inject these patients?
So that's what I haven't. I injected very rarely, but there are some of these, as you said, very high traction. They don't go down so fast, so it takes quite some time for that retina to settle. Or sometimes there is a the foveal contour doesn't come back in some of the cases. So is there any role for this giving intravitreal steroid? That's what I wanted to know. I
Yeah,
have
no,
injected in few cases, but not much of benefit I had got.
no. I after I start seeing patients, and if there is still edema, I don't see there is a rule. I just start with the drugs, and if they don't resolve, and then I could switch to the corticoid, which takes longer. Then it's a matter of a chronicity of the edema. But usually, the edemas resolve. They resolve. If you don't have more tractants, then that's normal history. But then, if you had these changes, structural changes in the IZ zones and cones, costs areas, of those distortions, and a longer edema for quite a while, then that could account for the worse outcome, worse prognosis. But these patients that remain or keep with some post-operative edema, I keep injecting them, and edema usually, if does not go away, gets better. I think we should have more of those cases to learn
Yeah, right,
uh, with
right.
the case.
Anything different in case in pediatric age group epiretinal membranes? Anything different surgically that you do, or how you decide
No, no,
to operate?
except it's a little, probably a little tougher, no? That probably the
Right.
membranes are more attached, but I would treat in the same manner. Good thing is to have good preoperative imaging, and if you can do that, and even though it's a pediatric patient, if you have good angels and images, it's good. I have done surgeries for a patient with toxocara. It was a boy, 4 years old. I operated him toe. Actually, 24 years ago. He's 24 years old, and he was starting this epiretinal membrane and traction, and I toxocaritis, secondary to toxocaritis. I did the surgery. He was
Right.
four
Right. Yeah.
years old. I spared the lens. The patient is still he was a little amblyopic. He was already 4 years old, but he's 2050 with 24 years old today, but with a clear lens. With a clear
Great.
lens.
Great.
He never developed a cataract. It's an interesting case. So I
Nice.
think if you operate on the case very early, as you said, and with a good
Right.
indication for the surgery, it's going to be just well. Of course, we have to remember the PVRs. We commented on the Miller cells and other potential problems. But if we get these cases early, so I think that's the best way to go.
Great. Thank you. Thank
Thank
you
you
very
very
much.
much, Jaydeep. Thank you very
A
much.
great discussion.
Thank you very much for everything. I would like once again to show you this.
Thank you again, Master.
My
Thank
pleasure, my
you.
pleasure. To show again, I will finish with this video again for the Retinawsome next Saturday. It's going to be very good discussion from Natarajan, from Vibehab, from Nageswar and all other friends from other countries, and I invite you to this event.
Sure. That's great. Wish you all the best.
So, Jaydeep, thank you very much.
Thank you. Thank
And
you.
maybe you could participate in the early future in our Retnason. That will be honor for us. Okay?
Definitely. That'll be great.
So bye-bye. Thank you very much for everything.
Thank you.
And see you guys
Have a great day.
next. You too. Bye-bye. Bye-bye, Nicole, Carlos, Otávio, Jaydeep. See you later.
Thank you.
See you next week. See you next.